This discussion is going to focus on pharmacodynamics. So some basic concepts. So we spent the whole previous talk discussing pharmacokinetics. So pharmacokinetics is essentially what the body does to the drug. So we went through that whole sort of four-part process and discussed, what goes on physiologically as far as like what the body does as far as absorbing, distributing, metabolizing, and excreting the drug. Well, now with pharmacodynamics, we're now looking at what the drug does to the body. So now we're now looking at what effect does taking, the particular drug is actually going to cause to the body. And essentially what we're looking at is, basically the drug having to reach a receptor site. So you're going to hear a lot about now drug receptors, because basically we're looking at the physiology of what's actually going to happen as the drug reaches the receptor. Because essentially most of the drugs that you're going to take are going to work at a receptor site. Not all of them, but a good amount of them. So the response of the drug is going to be based on basically two different factors. One is the drug's ability to bind to its target. So all the chemical composition of drugs are such that they basically, are, have a sort of a receptor or target that they kind of are matched with. So that's the first step. And then the second one is the drug's concentration at the receptor site. So the drug has to be at a certain concentration, obviously. So that's where obviously like the dose, how much of the drug you're taking is going to matter. So again, the goal is to get a general understanding of pharmacodynamics and to understand what's going to happen when people take various therapeutic medications. So the mechanism of action, is basically just the way the drug works at the target tissue. So when the drug reaches that receptor site, essentially how the drug is actually just going to work once it's there. And as I said on the previous slide, most of the drugs exert effects on drug receptors. So not all drugs do. Some drugs just kind of work locally within the body, but most drugs are going to basically have a matching receptor that's then going to create a specific action at the cell. Okay, so the receptors are basically just specialized target molecules, and they are embedded on the cell surface or within cell membranes. And when we've kind of talked about drug receptors already in the previous chapter, but we're going to expand and discuss them a little bit more in this one as well. So in this picture, you see various types of drug receptors. So again, just kind of orientate yourself to essentially what you're looking at. So this is basically the cell membrane. This is the inside of the cell. This is the extracellular environment. And here they're just showing various types of drug receptors that are present. So again, drug receptors are membrane-bound proteins, and they're actually present in different parts of the cell. There can actually be just some even drug receptors just even kind of embedded in the cytoplasm. You kind of see here some different examples of some of these different drug receptors. Again, so there's different examples. There's enzymes and nucleic acid-based drug receptors. And again, cells with different types of receptors combined with more than one drug. So there's various types of receptors on cells. Again, the chemical composition is essentially what's going to dictate kind of where the drug kind of binds within the body and in the cells, and then its ability to reach a therapeutic effect with select receptors. Okay, so basically, so essentially, and it's obviously a little more complicated than this, but if you think about a drug, the chemical that makes up the drug is specifically kind of designed to work within a receptor to cells. So, if you have cells that make up a certain part of the body or a certain body system, the drug is basically being designed to affect the drug receptors within those particular cell membranes. So looking at this, so the site where the receptor, or the site on the receptor where the drug binds, is called the binding site. So if we're looking at some of the information here, so the drug receptor binding is basically related to the three-dimensional structure, shape, and reactivity of the binding site. And the inherent structure, shape, and reactivity of the drug. So basically, those two things have to be compatible with each other. So if you look at this kind of illustration over here, and this is something out of your textbook, so the key, so they basically look at what they call a lock and key mechanism with again with all of your drugs that work at a receptor, which again are going to be most of the drugs. We're going to talk about throughout the course of the semester some specific drugs that don't act at a receptor. Most of them do. So here's kind of the reaction for most of them. So the key is the drug ligand. The ligands are basically responsible for either activating or inactivating a receptor, okay? And what that's effectively going to do is either increase or decrease the function of a cell. So if you think of most drugs that people take, they either cause a specific increase in a response in the body, or they decrease a response or try to suppress a response. And that's basically what's going to happen with the drugs. So you have the key that fits, and again, they're going to be specific to a receptor. So that's why they're kind of showing this picture here as far as the adaptability of the particular drug to the receptor, and the shape is going to matter. So, you know, molecules of different shapes, and as long as they have the right shape, they can go into the receptor and create that particular response. Then within this you have, so then you'll then have a drug receptor complex. So once the drug and the receptor kind of come together, if you will, you have the drug receptor complex. That's going to unlock the drug to act at the target tissue. Once that complex is created, so once the key kind of goes into the lock, if you will, and kind of, if you will, unlocks and either, again, creates a response or suppresses a response, there then is various alterations in the molecular activity of the cell, okay? And that molecular activity of the cell is what they call signal transduction. So that's going to create alterations, and then those different things are going to take place. And then at some point, that binding of the drug to its receptor could either fall into one of two categories. You could either have what's called reversible binding, and that occurs when the drug can separate from the cell receptor, kind of like taking a key out of a lock, okay? So, and then once the key comes out of the lock, if you will, then basically the effect of the drug stops. Or you could have what's called irreversible binding. That occurs when the drug is not able to separate from the receptor. And what that does is prolongs the drug's effect. So that's when we start to get into some things related to dosing and timing based upon those particular categories. So now, beyond having the right sort of molecular shape to create a response at a receptor, you have to have a certain dose of a drug. So you have to have a certain amount of the drug. So this is where we get into kind of determining, you know, how much of a drug takes place is through dose-response relationships. So in general, again, for most drugs, as the dose increases, you do get kind of a greater individual patient response. Now, just because you get a better response as far as what the drug does, there is the potential at some point for drugs to obviously start to have harmful effects. So when you're kind of looking at a drug and how much should be taken, and we kind of talked a little bit about drug dosing in previous chapters. So we have a couple different levels here we have to look at, and you can kind of, again, refer to the figure on the side here. At first, you have what's called the lethal dose. And that's the dose of the drug that's lethal to 50% of the population. Okay, so the lethal dose is usually determined experimentally. So when a drug is kind of going through experimentation, and this is usually by, you know, administering the chemical to mice or rats. And when they determine that, like, you know, for the human population, basically the dose that's going to be lethal to at least 50% of the population. Then you have the effective dose, and that's when 50% of the population basically gets, you know, desired effects from a drug. So again, lethal dose, 50% of the population, the dose of the drug is lethal. Effective dose, 50% of the population gets basically the desired response. Then from there you get what's essentially called the therapeutic index. Okay, so the therapeutic index or therapeutic ratio basically looks at the relative safety of the drug. And that's also related to something else called the therapeutic window. Okay, so the therapeutic index is the therapeutic window calculated with that little equation that's on there. And essentially what that's saying is that the higher the therapeutic index ratio, generally the safer the drug is. Okay, so if that ratio tends to be higher, again, there's always going to be the potential for negative effects to any drug. Essentially, any drug that you take, doesn't matter over the counter, prescription, there's always the potential to have negative effects. But for the most part, a drug is considered safer if that ratio with the therapeutic index is higher. The lower it is, just the greater effect, the greater chance that an individual could get negative effects from the particular drug. So again, looking at drug receptor interactions. So again, here again, very similar picture, kind of showing drug receptor interactions. We're going to talk about basically drug receptors having two states. Okay, so they basically have two conformational states or shapes, and they're reversible equilibrium with each other. So they have both active and inactive states. So basically, the pharmacological properties of drugs are based on their effects they have at receptors. In the case of an agonist is going to activate a receptor. So they favor active receptor conformation or active receptor shapes, and they're going to facilitate a response, as opposed to an antagonist, which is going to be a drug that inhibits a receptor response by basically blocking or preventing a response. Okay, and this is going to be what we would call an antagonist. So, and you have two different types of antagonists. You have a competitive antagonist, and that blocks an agonist from binding to a receptor. And then you have non-competitive antagonist, which binds to a different site. So if we look at this illustration over here, so this whole concept of conformational states or shapes, if we're looking here, so in letter A here, you basically have, they're showing a receptor that's unbound and available for binding. Okay, so there's an inactive receptor, nothing is bound to it. You see the little shapes here. So you have the agonist binding site, and then you have what's called an allosteric antagonist binding site. So there you have both of those sites. In the case of B, you have agonist binding. So here's your agonist. So here you have a drug that's an agonist, then binding to the receptor. And then that's going to basically, with the agonist, it's going to activate the receptor by inducing a conformational change in the receptor. So because of the fact now it's in there, it's kind of changed the conformational state of the receptor. And in certain cases, there's going to be certain actions that are going to take place within the cell. Okay, if we look over here, we have a competitive antagonist binding. Okay, so here's your agonist, here's your competitive antagonist. So instead of the antagonist kind of binding to that allosteric site, what it's actually doing is kind of getting in the way. Okay, so here's the agonist, here's the competitive antagonist. The competitive antagonist comes in and basically blocks the agonist, as opposed to over here where you have what's called a non-competitive. So competitive, it's basically competing for the same site. Okay, blocks it and prevents something from happening. In the case of a non-competitive antagonist, the non-competitive antagonist is going to bind to a site different from the agonist site. So in this case, the antagonist binds to the same site. That's competitive. So think it's like basically competing for the site. The non-competitive antagonist is going to exert its kind of blocking effect, if you will, by binding to a nearby site. Okay, so that's basically what you're looking at. So you either have an agonist, an antagonist. The antagonist could be either competitive or non-competitive, and that's gonna basically dictate what and where that particular drug is going to attach to. So talk a little bit further about agonists and antagonists. Again, as we already defined, agonists are drugs that produce a desired effect in binding with a receptor. So basically, when a receptor gets bound by an agonist, or an agonist kind of makes that connection at that site, most of the receptors are going to be activated by basically stabilizing the receptor in a specific shape or conformation, and that's going to produce a response. So for instance, a lot of hormones in the body, a lot of your neurotransmitters in the body basically act as agonists. Okay, so circulating hormones, which of course, obviously, if someone were taking hormones pharmaceutically, it would work in a similar fashion. They basically kind of match up and are producing a response at a cell. Okay, and basically you're going to get your maximal response to a drug kind of on that dose response curve is going to happen when all the receptors are occupied by an agonist. Okay, and then really at that point you're going to get no additional response. So basically by further taking the drug, you're likely not going to get much more of a response, and then that's when harmful effects from the drug could potentially happen. Two different categories of agonists. You have an inverse agonist, and that's when those are agonists that bind to the same receptor as agonists but cause a different response. So basically you're trying to induce a pharmacological response that is opposite to the agonist. Okay, that would be the example of an inverse agonist. It's not the same as an antagonist. An antagonist is going to block a response. This just produces a different response in the case of an inverse agonist. And then a partial agonist is when it's going to bind to an active receptor and activate the receptor, but only have partial efficacy related to a full agonist. So you're not going to get the same full efficacy as you would with a full agonist. Again, antagonists, drugs that diminish or prevent the physiological effect of agonists. And again, we've already talked about the difference between a reversible and irreversible. So reversible antagonists readily disassociate, and again, they tend to just come off the receptor. The irreversible antagonist basically forms a permanent stable bond with the receptor. So the important thing with the antagonist to remember is that, again, so they could either block or reverse the effect of an agonist. So a good example of an antagonist is Narcan or naloxone. Okay, that's an opioid antagonist that is structured related to morphine. So naloxone has no effect on its own, but will basically reverse the effect of any opioid agonist that has been administered. So Narcan is really important for individuals who are possibly overdosing, for instance, on opioids. So you've probably heard of naloxone or Narcan, and that's basically probably one of the more prominent antagonist drugs. Sometimes antagonists can also reverse or block the effect of endogenously produced compounds. So endogenously just means produced by the body. So that's kind of another way that kind of antagonists will work in the body. That brings us to kind of looking at drug dosing. So obviously the dose of the drug is going to kind of is going to be kind of based on, number one, how much is needed to get an effect, and at what point are we going to start to, either not see positive effects or potentially start to see negative effects. Okay, so anytime particularly for prescription drugs, when a provider is going to prescribe a drug for a person, there's various things that have to be taken into consideration. Obviously, one is the risks and benefits. So if a person's going to take a drug to treat a condition, you have to weigh, what are the risks, what are the potential negative things, but what are the benefits, okay? That's going to be something that comes into place. You look at the medication profile, and that's going to basically, again, kind of take into consideration what the medication's actually going to do. The patient profile, so what's the patient's current health status, age, gender, what's their specific medical problem, are there any genetic determinants, any issues associated with that, and in the end then too, what is the diagnosis? So what's the actual pathology that's getting treated? So again, whether a drug is going to be kind of indicated is going to depend upon kind of, again, a balance between therapeutic benefits and any type of adverse effects. And, many times in certain, judgments of the medical professional, they're going to use, personal experience. So there is some subjectivity to it as far as whether or not a particular treatment will actually be utilized for somebody. Either way, when we start to look at dosages, and drugs are available in various dosages. Many times you have just what's called a starting dose. So with many types of drugs, and again, it tends to be a lower dose. Many times people do start kind of on a lower dose of a medication. And basically, we're just looking to basically reach a therapeutic level while trying to minimize any potential negative effects. And then essentially what's going to happen is the patient's going to be monitored to make sure that they're getting a therapeutic response, because if they're not getting a therapeutic response, then the dose may have to be adjusted. But many times with a lot of medications, they will start with the kind of lowest possible dose, see if there's a therapeutic response. If there's a therapeutic response, then you just stay at that lower dose. And then over time, adjustments will be made as needed. So, patients will be monitored with, more closely with certain drugs than others. Again, certain drugs don't require as close of monitoring, but the patient will just basically be monitored as long as, they're getting therapeutic effects, while minimizing any side effects. They'll kind of keep the dosages as they are. So looking at dose response, so again, the drug affinity is basically going to be how tightly the drug binds to the receptor. So obviously the receptor has to have affinity of the drug to have positive effects. Then you have the intrinsic activity, which is the drug's effectiveness relative to other receptors. Okay, so both affinity and activity are going to be determined by its chemical structure. So again, this is where the chemical structure of the drug comes into play and is really important as far as the drug being able to exert specific effects. Okay, selectivity is the extent to which the drug will act on a specific receptor. And then you have the specificity, which is basically going to be secondary to the drug's chemical structure. So again, here we're just kind of looking at some different definitions as far as, like, again, that whole drug receptor kind of interaction. So again, both affinity and activity are basically going to be dictated by the chemical structure of the drug. The chemical structure of the drug is going to be very important, because that's going to be what kind of dictates where they're going to act at those specific receptors. Just one more point looking at specificity. So a drug that interacts with a single type of receptor on kind of a limited number of cells is actually going to exhibit very high specificity for a cell. That's as opposed to a drug which is kind of found throughout the body, which can have more widespread effects. So most clinically important drugs have very low specificity, because they're going to interact with kind of multiple receptors in different tissues in the body. And what that effectively does is it allows for a lot of utility with a drug, because it kind of can basically sort of have many different kind of clinical applications. Now, the kind of the drawback to that, so that sounds really good. You're like, wow, you have this drug that, could kind of do multiple things. So it's not highly specific, but it could kind of, kind of manage different aspects of certain pathologies. However, a lot of broad specificity, even though it enhances, its usefulness, it could also kind of increase side effects. So if a drug basically has very low specificity, while it can be used to treat various things, it also increases the number of potential adverse side effects, just basically because of, as I believe your book uses the term off-target interactions. So for instance, they give an example of a drug used to treat cardiac arrhythmias, aminodarone, and that's an agent but it's very broad. So obviously there could be multiple types of cardiac arrhythmias. While it's nice because it kind of has like a kind of a widespread clinical application, there's also the chance, much greater chance. So as opposed to a drug that is very specific, it may not have the, overall clinical usefulness to treat something, but you kind of limit some of those potential, non-intended or negative side effects. So that's the example that I just gave with the broad specificity. So again, that particular type of drug can cause, again, it tends to have greater side effects with when individuals take it. So two other terms we look at are potency and efficiency. And these are easily confused. So it's really important to be able to differentiate between potency and efficiency. So potency compares different doses of meds that produce the same effect. So potency is basically used to compare different doses of two medications that are going to produce the same effect. That's as opposed to efficiency, which is the strongest effect that a particular drug can produce. And those responses are going to be basically determined by what we call half maximal effective concentration. So actually on the next slide, I'm going to have an example of this with two hypothetical drugs, and we're going to talk about the difference between potency and efficiency. So again, potency is just basically comparing doses that can produce the same effect, and efficiency looks at just basically the overall strongest effect that a particular drug can produce. Okay, as I said, well, there's a little illustration, it's in your text, but I'll explain it on the next slide. Um, Important to kind of ensure safety and efficiency. So again, we want to make sure that drugs have a good response in the body, because we want that therapeutic effect. There's something called therapeutic drug monitoring, and this is critical to ensure both safety and efficiency. So certain drugs, as I kind of discussed earlier, they do need to be monitored a little bit more closely. Many times you'll get, prescribed the drug, and you'll just, kind of take the drug, and unless you have any problems, you'll just kind of finish out whatever prescription, or if it's a drug that you just need to take for an ongoing condition, you'll just take it. Certain drugs require a little bit closer monitoring, and, primarily that's because there's a much greater risk of effect. So for instance, the book kind of gives a little example with vancomycin, which is a common antibiotic used to treat methicillin-resistant Staphylococcus aureus. And this is something that in athletics environment is still fairly common. So this is a bacterial skin condition that can have very negative effects. Vancomycin is very commonly used for this. Excessive use of it can cause hearing loss or acute kidney damage, and this requires, so there's regular monitoring of this within 48 hours. And kind of the reason why this is important, and this is kind of highlighted, is because, particularly with athletes, highly motivated athletes could sometimes opt to self-medicate. So they think if some of a drug is good, more of it's better, and it'll help clear up whatever condition they have. So if someone were to go against medical advice with dosing, so it's very important to highly monitor, particularly with drugs like this that could potentially have a lot of very negative effects if taken in too high of a dose. So as I said, we were going to kind of show that little graphic on potency and on efficiency. So here, if you look at A, okay. So this is looking at looking at drug potency. So again, you have that half maximal concentration. That's what the EC50 basically is representing. Okay. So here you're looking at potency of two drugs. So you have drug X, you have drug Y. Okay. So drug X reaches that that half maximal effective concentration at a lower dose, which means that drug X is going to be more potent. So drug X in this case is more potent than drug Y, because it's basically reaching that EC50, or that half maximal effective concentration, at a lower dose. So if you can take a drug at a lower dose, it means it has better potency, or it's just a more potent drug. Okay. If we look over here at the efficacy, so efficacy again relates to the strongest effect that a drug can produce. Okay, so here we're looking at, again, two hypothetical drugs, drug X and drug Y. the responses are 100% for drug X, 50% for drug Y. So in this case, drug X, okay, so our hypothetical drug X is not only more potent, but it's also more efficacious than drug Y. So again, this just illustrates those two things that I had talked about on the previous slide. So one particular drug, and opioids even recently have received a lot of attention. So obviously one of the more common things, particularly in a sports medicine environment, we're going to treat as pain. Okay, and pain is a very complex thing. We discuss pain in various classes and have different ways to do this. In the case that we're treating pain with opioids, and we're going to spend time talking about both pain medications, both non-opioid and opioid applications of drugs. Again, treatment of pain with opioids. Some opioids transfer rapidly, can either transfer rapidly or slowly. Some have both high or low potency. Okay, so the transfer between the plasma and the target site strength is going to be classified whether or not an opioid is considered a high or low potency opioid. Okay, so for instance, if we look at codeine, codeine transfers to morphine in the CNS via what we call the P450 system. Oxycodone has very high potency. It's basically effective if there's no delay at the site of action, and the metabolites of both oxymorphone and neuroxymorphone basically are going to contribute to the analgesic effect or the pain relieving effect of opioids. And again, we're going to be spending time on chapters kind of further discussing different type of opioids, how they work at receptors. So again, a lot of your opioids are going to work at the CNS because that's where that pain is going to get blocked. But we'll spend more time talking about those. This just kind of gives you an idea in as far as basically how fast they transfer, and that just understanding the fact that some are very high potency, some are very low potency, and again, they're going to be utilized clinically based upon what type of response we're looking for. And then drug potentiation. So potentiation is when one drug interacts with another to either give a greater response than if the drugs were used independently. Okay, so in some cases we want potentiation, and in some cases we don't. So this is part of the reason why we have to be careful and make sure that we're educating drugs, because a lot of times we don't want to have that greater pharmacologic response. So, for instance, this is why many times we have to be very careful with consuming alcohol. So if someone's taking a prescription drug that could potentially cause sedation, they should be discouraged from using alcohol. So for instance, opioids are an example, where alcohol, they really shouldn't consume alcohol when taking an opioid. And that's just because alcohol could potentially magnify a lot of the sedating effects of those medications. Kind of less common is, an NSAID plus an anticoagulant could potentially increase bleeding. That's because of the effect that NSAIDs have on the effects of coagulation of blood. So those are some things you want to look at. So anytime a drug could potentially cause this, you have to make sure that there's no interactions, whether that's with another over-the-counter drug or in the case of something like alcohol. So again, that's why it's important to be familiar with risk and adverse effects of medications, to make sure that there's no other interactions, or it's also why it's important to know if someone is already taking a particular type of drug, because if someone is, then that may kind of impact what's going on treatment-wise for particular conditions. It's kind of in summary, again, the pharmacodynamic effects of, looks at the effects of drugs on the body. So again, what's important here is it gives the athletic trainer kind of a greater understanding of kind of how drugs are working in the body, and just kind of understands those particular drug receptor interactions. Again, it's going to be really important, particularly for some of our more common medications that we see in sports medicine settings, to kind of understand how they work. Again, the fundamental relationship of the lock and key, and we kind of talked about how, again, drugs have a certain chemical structure and shape, and that's going to be what kind of dictates what receptors they work at in the various cells and therefore tissues in the body. And again, it's just going to make sure that, we have kind of an understanding of, again, the therapeutic effects and also to the potential adverse effects of different types of drugs. And these are your learning objectives based upon the information we discussed.